invite engaging discussions around global health, whether that be research, policy or practice. And I'm personally so delighted that we have Dr. Sinead Walsh and Oliver Johnson to present today. And they're here to discuss the background to their book, Getting to Zero, the story of a doctor and a diplomat on the Ebola Frontline. Without giving too much away, Sinead was head of Irish Aid and Irish ambassador to Sierra Leone for quite a while, but particularly around the 2014 outbreak of Ebola in Freetown, where Oliver was the doctor-in-chief as such, I don't know if that's a term, but at Connaught Hospital in the capital. And this discussion is a conversation around that time. They were working in the same town in response to a similar humanitarian crisis. The book will be available, Oliver and Sinead will be signing copies after. And without giving too much away about it, in the words of Tulip Mazumdar, Global Health correspondent to BBC News, she describes it as a frank, beautifully written and essential guide to the lessons learned from the heart of the outbreak. Their first-hand experiences in battling this terrible disease will take your breath away. So, over to you.
Thank you very much.
Hard to live up to Tulip's words. But it's great to be here. I think we're keen to really talk to as many people as we can about the book, because I think we were both involved in this crisis quite accidentally, so the same thing could happen to any of you potentially. So we tried to write the book that we wish we had read, maybe. So it's good to get around and talk about it a little bit. We'll sort of run quickly through some of what happened, because maybe to refresh people's memories a bit, although you were probably following it as global health types at the time. As Anna said, we were there for entirely other purposes. I had been in Sierra Leone for about 3 years when the crisis started, or when we started hearing about Ebola being in the sub-region, and mostly working as the head of the Irish Aid program on nutrition, women's rights, teenage pregnancy, those kinds of issues. And Oliver, as he'll talk about, was the head of this small King's team working in the main hospital in Freetown. I think one of the things that's important to know is that, of course, no crisis happens in a vacuum, right? So there was a whole range of really, really kind of burning issues that we were working on at the time in Sierra Leone, and sort of thinking back to that time when we first started hearing that Ebola was in the neighborhood in one of the neighboring countries, we were really, really kind of feeling under pressure. We thought there would be a food security crisis, which in fact there was in the summer of 2014. So in the spring of 2014, when all of this was kicking off, we were sort of strategizing, with the government and other internationals, how do we prepare for this? How do we mitigate against this? Issues, climate issues, failing harvests, and so on. And just to sort of give you an illustration, 70% of the population of Freetown is about 2 million, and 70% of the population live in slums, right? So this is one slum, one particularly kind of harrowing picture that gives you a sense, I think, particularly as a group of sort of health folks, of how difficult it must be to promote health and sanitation and hygiene when most of the city is actually living in these kinds of conditions. But more broadly, Sierra Leone is a country where about 1 in 5 children don't live to see their 5th birthday. So it's got one of the highest child mortality rates in the world, one of the highest maternal mortality rates in the world. 1 in 10 girls will finish secondary school, just to give you an example. So a very, very challenging context, also very challenging from a governance perspective. When we were kind of in the lead up to the Ebola crisis, Sierra Leone, Transparency International ranked Sierra Leone #1 in the world for bribery, in order to receive a public service. So we were working on a lot of these kinds of issues in the spring of 2014, and feeling pretty sort of overwhelmed about it. And then we started hearing about this outbreak in Guinea. So if you see that red circle there, it's basically an area which borders Sierra Leone, Liberia, and Guinea. So the first case was close to Kisudugu, and it was a very remote area. And I think one of the things that's maybe remarkable, which came back very much to haunt us, was that the first cases of Ebola ever in West Africa emerged in this area where sort of an ethnic group called the Kissi were traditionally living there. The borders were sort of reasonably meaningless because they had been living there before it was all decided to carve up this territory into between different colonial powers. And so generally this is a group which in the three countries, particularly in Sierra Leone and Liberia, was pretty kind of marginalized, very far away from the capital city, often sort of more political opposition than the governments in place at the time, so really not getting much in the way of public services or anything like that. So quite a self-reliant kind of a group who wouldn't necessarily in general have much trust in government or in outsiders. And so I think this is, the geography of what happened here is really important. And essentially the first case was an 18-month-old baby called Emile Mwamwano, who most likely, we think, played in a tree close to his home in his village that probably had bat droppings, and he most likely had some kind of interaction with the bat droppings, and then had maybe a cut on his hand or something like that. And this was the first ever Ebola case in West Africa. But because we had no background in West Africa of having Ebola, and the previous outbreaks had been in Congo, it took 3 months, to diagnose that this was the disease that was killing all these people. That was, so in March of 2014, we started hearing about this. But I do remember feeling very strongly that maybe, given everything that we were trying to deal with in Sierra Leone at the time, maybe Sierra Leone might just dodge this bullet and not sort of get this disease. And then Oliver will tell us what happened next.
Yeah, so I was based, I was 27 or something, and I was working for King's College London. They have a global health department, a bit like the George Institute here, quite a small new department with a long-term interest in doing health system strengthening partnerships. So we've been working in Somaliland for by then about 15 years, supporting the government on things like medical training, hospital strengthening and so on. And I headed out in January 2013, having been there as a medical student for my elective. I went out to help set up a partnership between the main teaching hospital, the main medical nursing pharmacy school, and the Ministry of Health with King's. So initially it was me and it was a couple of colleagues embedded in the main hospital. We had a little office next to the medical superintendents, not doing clinical work, but mainly trying to support long-term things like redesigning their medical curriculum or improving their triage systems, these sorts of things. Very little funding. And then we heard about the Ebola outbreak in Guinea. There was the minister formed a task force in the ministry of UN agencies, international partners, people from the Syrian government, and we were asked to join. Very luckily, a Spanish infectious disease doctor joined my team the week that the Ebola outbreak started. So we happened to have someone who knew about infectious diseases. And funnily enough, almost all the work we had been doing prior to that was NCDs. We were doing surgery, we were doing mental health, we were doing dentistry, other things. We weren't doing any ID. And I said, what am I going to do with an infectious diseases doctor? But she's really great, so we'll take her anyway. And then, of course, we hear about the Ebola outbreak, and so started advising the Ministry of Health a bit on how to get hospitals prepared for a possible Ebola outbreak. So we downloaded the WHO guidelines. We kind of thought WHO would be doing this, but we had the clinical group meeting happened and no one from the WHO showed up, and in fact it kind of turned out that almost no one at the WHO had a clinical or any recent clinical experience. It's very much a kind of epi-public health background. So when it came to the more clinical side, there was very little contribution from the WHO. So in the vacuum, we kind of stepped in to support, and what really happened in those early days, because we had about 2 months from the first case being diagnosed in Guinea to the first case in Sierra Leone. So we had a little preparation window. So we were in these planning meetings trying to get hospitals ready, but it was really a paper exercise. We produced these guidelines in the office of the director of hospitals at the ministry, and we said, do you have a list of hospitals so that we know who to send these to? And they didn't have a list. So we had to call around and work out what is a list. I mean, that's how it was a one-man directorate for the entire country. Even if we got the email addresses, the chances that the doctor, the medical superintendent of a rural hospital had internet access was very low. If he did, the chances the printer would be working. So even physically getting a copy of the hospital guidelines to the rural hospital was just, it took us weeks, and in the end we had to call around NGOs and beg and borrow, could you just print these as a favour and drop them off on your way home? And so if they were lucky, they had a printed copy of the guidelines. The training that happened, one doctor and one nurse from each hospital went for, I think, 2 days to a place called Kenema, where they got basically PowerPoint training, slides about Ebola, and were then sent home back to the hospitals to train the trainers. No supplies, no hands-on training. And so the reality was, while everyone was saying, we've done the guidelines, everyone's trained, the reality was that really no support had been given. And therefore, as Ebola quickly began to spread from the east of Sierra Leone, near that border, towards Freetown, what we saw is very quickly a lot of health workers getting infected, because a patient would walk in, they would have a fever, they would have a headache, people would think this is just malaria, let's put them on the ward, no gloves, no hand hygiene very quickly, a lot of chains of transmission, huge numbers of health worker infections. So this is the room originally at Connaught Hospital, the main adult hospital, where we had 2 old cholera beds, and King supported the hospital to set up a small Ebola unit. And then one day we had one patient who had symptoms who we isolated, and then a second in the afternoon, and then later in the afternoon a phone call from the emergency department saying they had a third case, and we didn't have any beds to isolate them in. So that night we got together with the hospital, the medical superintendent decided to shut half of the emergency department to make a bigger Ebola unit, and so we built this in about 4 hours. You can see us working in this sort of dusk. We were there till about 11 o'clock at night. It was an incredible kind of moment of the hospital coming together, and maintenance staff and putting up plastic sheeting, but very, very basic stuff. And we thought maybe we'll see 5 or 10 Ebola patients, because this is going to be a rural outbreak, it's going to be based in villages. The conventional wisdom, and this is one of the learnings, is don't never believe conventional wisdom. The conventional wisdom was Ebola doesn't cause big urban outbreaks. So we thought maybe someone sick in a village will get on a bus to Freetown and they'll end up here. But we're not going to see very many cases. In the end, we saw over 1,000 patients in this room, in which more than 750 tested Ebola positive, and that's nearly double the total number of Ebola cases from the largest previous outbreak. So what we were dealing with was just a different order of magnitude than what anyone had seen before. And so we set up this unit. We ultimately supported 6 other hospitals in the city to set up their own Ebola holding units like this. And then we also, one of the things we realised, I went to the military hospital in Freetown, which was very organised, and they had a functioning Ebola unit. But when I went there, even as we at Connaught pretty quickly had patients dying on the steps of the hospital, we had no beds left, we were full. We couldn't take in more patients. People say, why don't you just fill the ward with Ebola patients? But so many health workers, including the Sierra Leone doctor in charge of our unit, were dying, and that's when we kind of had to step into more of a leadership role. We couldn't just fill wards with Ebola patients, and so we had all these patients dying on the tarmac outside the hospital. And then I went to the military hospital, and it was half empty, because there was no coordination. There was no coordination mechanism for ambulances, for lab supplies, for protective equipment, but also for patients. And so Amar here, and this is one of our messages in the book, is that individuals can have a really big impact on the outbreak, and they're not always individuals you would expect. And so Amar was actually setting up this command centre, and her background was as a stage manager for Wicked the Musical in London. So that was her career. She then went to Sierra Leone as a teacher, a volunteer teacher, and then I said to her, look, if you stage managed a musical, you probably know how to coordinate ambulances, much better than a doctor would. And so this was it, and you can see it was, just getting together some flip chart paper and some whiteboards. And down here, this whiteboard below, was actually long lists of patients who had been identified as probably having Ebola, but there wasn't a bed for them. So they were quarantined in their homes, and it would say such and such a person, 22 years old, vomiting, diarrhea, quarantined with 17 family members in one room with no running water for day after day after day. And of course that just meant that the infection spread and spread because we didn't have enough beds. And this was, so it's the 29th of September. So this is 4 months after the outbreak started in Sierra Leone, 6 months after the outbreak started in West Africa. And this was the response that existed at that time. You know, this was the total number of beds in Freetown. Hardly any beds. 3 of these units were being run by a British university, one by the Sierra Leone military, one by an Italian NGO. And every day, it's 0, 0, 0. And of the total beds in the country, these treatment centres full, full, full. And day after day after day, you know, we might have a couple of patients die, we would clean their beds, the beds would get filled in moments, and we would be back to this situation. And so it was a really desperate period of time where we felt so overwhelmed. And the CDC at around this time produced a model, and they suggested that if the outbreak didn't improve, the total number of infections in Sierra Leone and Liberia could be 1.4 million. Now that would be about 1 in 10 of the population. So there we were, just imagining, we had about cases in Nigeria. We had no idea how far across the continent, how far across the world this outbreak was going to spread. But also within Sierra Leone, 1 in 10 people gets infected. What happens to your police force who stop coming to work? What happens to your government in a post-Civil War country? So we also just didn't know what was going to happen to the state when an outbreak took hold that hard. And yet still, there was almost no meaningful response on the ground. So I'll hand back to Sinead to pick up from there.
So I suppose what I was doing was mostly talking to people like Oliver and health workers in different parts of the country and trying to point these things out at the national level, at the international level. We had a very ineffective presidential task force that I sat on that didn't really achieve very much and would have 5-hour meetings. Nevertheless, we had, international media would occasionally come, and we would try to speak to them and have all sorts of video conferences with WHO in Geneva and various people in New York and so on and so forth. But it just didn't really ever seem to lead to anything in terms of what was happening on the ground. And we found this really baffling because, you know, as Oliver said, I mean, we felt like this was Armageddon. You know, it was sort of, you know, I suppose, and maybe an infectious disease crisis is a bit unique in this way. I mean, things are not just horrendous. You have absolutely no idea how bad things are going to get because it's exponential, right? So it was just a really surreal period. And nevertheless, the world did seem to be asleep for these, these critical months, I would say up to about September. And I think for Oliver and I, and we sort of discussed it later, that we both sort of had this, feeling that, any day, the cavalry is going to come in, the international cavalry of people who actually know how to deal with these diseases, people who've done it before, people who have expertise, are going to sort of sweep in, finally realize what's going on, sweep in, and then, the rest of us who are, entirely unqualified, we will be able to step back and kind of let them do their job. And I mean, that never happened actually, and I think it's one of the things that we learned. I mean, we did get an enormous international response. The lady in the middle here is Samantha Power, and Barack Obama in September were, I think, quite in the leadership role here. They were chairing the Security Council at the time, and at some point, they just got on the phone and they just sort of called world leader after world leader after world leader and sort of said, what can you do, and so on and so forth. And eventually there was this agreement that, the US would lead the support for Liberia, the UK would lead the support for Sierra Leone, and then people said the French would lead the support in Guinea. It never really quite happened in the same way in Guinea, but that certainly was how it played out. So in Sierra Leone then, we started to see, hundreds of, ultimately thousands of staff coming over, all sorts of ambulances. I mean, with a huge ramp up of the response from September onwards. But the reason I say the cavalry never came is that actually it took a very, very long time for those resources to translate into real, benefits to the population, because everything that was coming had to then somehow function in the local context. And the local context was very complicated, very politicized. There was all sorts of specificities, and of course any international response, as we learned, will have to then somehow operate and maneuver in that context. So actually people like Oliver and myself, who'd been in the country for some years, actually still had to sort of operate and work, but in a different way, more in terms of helping this big response to actually get some results. And it took a surprising amount of time. In fact, from the first case in Sierra Leone to getting to the zero part of getting to zero, it actually took 21 and a half months, and that's, I think, often quite surprising to people I speak to here, because they're like, oh, but I saw it in the media, but I kind of saw it for a couple of months and then it was gone, so I sort of thought it was fine, once I stopped reading about it in the headlines. But actually the getting to zero part took a really, really long time and a massive, massive effort, because we had let it get so absolutely enormous. And I think this was really what kind of led Oliver and I, sort of quite accidentally actually, to the conversation about writing something down, which I think at the time we probably wouldn't have predicted would be a book, but we ran into each other sort of accidentally when we were sort of at this zero, getting to zero, and people were saying, oh, we'll have celebrations, and there were celebrations, and in a way that was deserved, because there was a lot of really hard work involved in getting to zero, but we felt very uncomfortable about it, because I suppose, unlike a lot of people who'd worked on the response, a lot of the internationals who'd worked on the response, we'd been there before it started and then for the entire cycle. So it was very difficult for us to feel self-congratulatory, because we were haunted by all the mistakes that had been made by ourselves, by others, and the costs of that, and the thousands of people who had died unnecessarily. An Ebola outbreak, it may inevitably kill the first couple of people, because it's very unpredictable when Ebola might pop up, but it should never kill, thousands and thousands of people. And so in the end, in Sierra Leone, the figures we know is that 3,956 people died. We know that's a huge understatement. We know there were lots of people in the early days in that red circle on the map who were their names were never recorded. We also know now, and we have research that shows this now, that more people died of non-Ebola diseases during the Ebola crisis because they weren't able to get care. So HIV treatment interrupted, TB treatment interrupted, childbirth, not being able to get assisted childbirth, malaria, because it had such a huge impact on the healthcare system, and we did a really poor job addressing those secondary impacts of Ebola. So we decided that we would write something down, which ended up being this book, partly to speak frankly about the mistakes that were made, and also to tell some of the stories of people who can't tell their own stories, like some of Oliver's colleagues who made great sacrifices and didn't live, and others who did live, but for whatever reason are not able to sort of talk about what they experienced, but they can talk to us anonymously, of course. So we tell a lot of stories in the book, from our own experiences and our colleagues. To try to give, I suppose, a bit of a holistic picture of what we and our colleagues experienced in that time. So just to maybe finish up, we had 5 big lessons in the book. So we'll just run through them really quickly. The first one, and by far the most important, we would say, is the whole area of community engagement. And this was the biggest failure of the response. We had a tendency to, just like you see in this picture, give people instructions, with a poster or a loudspeaker or a radio program, you should do this, you should do that, which just didn't work. And anybody who has any kind of background in anthropology or even just in community work in general, of course we know it doesn't work. We know that, we don't change people's behavior by, giving them instructions. We need to actually really sit with people, listen to them. There was huge fear surrounding this disease. People had never seen it before in West Africa. There were conspiracy theories everywhere. So we really took the wrong approach for most of the response with our kind of instructions. And towards the end of the response, we did start sort of copping on to some of this, and we had some better practices around, really starting with where people were, listening to their own ideas for how they could overcome this disease in their own communities. But it really took us far too long to get there. So we tried to showcase in the book some of these things, in order that even in the current outbreak in Congo, for example, that we can hopefully help some people generate some better ideas, because this, as I say, was our biggest failing. The second lesson then is around leadership and coordination. I mean, Oliver mentioned WHO. This has been well documented. I think it will not be news to you that WHO really, did not step up in the beginning of the crisis at all. They really failed to lead. The government of Sierra Leone also failed to lead, I think both of those bodies improved a lot actually over the course of the outbreak, and I think WHO did learn quite a lot of lessons from the response. But at the time, there was a big vacuum of leadership, and it should also, I should also say that, the British government, although it was belated, when they really committed to assisting Sierra Leone, from kind of September, October onwards, they really did, play a really important role in leadership, and they did transform their response. And I think that's important to recognize as well. We also have some criticisms of how they did things, which we talk about in the book, and we talked about with them yesterday when we went to DFID. But I think it's really important to recognize also the strong leadership role that they played. The third lesson then is around politics and accountability, and this is maybe surprising to some people that people maybe think, oh, Ebola, it sounds very complicated and all that kind of thing. Actually, the vast majority of challenges that we had working on the response were not technical, they were political. Every single day we were plagued by political issues, sometimes vis-a-vis international organizations, sometimes vis-a-vis national government and other actors, people trying in various ways to take advantage, power issues, corruption, kickbacks, all this kind of stuff. This was really the really critical thing that we dealt with. And I suppose one of the lessons is that, in a humanitarian crisis, as we said, no humanitarian crisis happens in a vacuum. So what is our, how do we, as people working in a humanitarian crisis, what efforts do we make to really understand the context where we're working so that we can actually try and mitigate some of these issues around politics and so on. And I think that's an area where sometimes as internationals we don't sort of take that seriously enough. But yeah, this was a big constraint, and I think in the book we found, when we sort of did a review of the hundreds of reviews that had been done of the Ebola crisis, we found that this area almost never came up, and there's probably, I think, a lot of political correctness around, people are like, well, I don't really want to talk about that, so I'll focus on the fact that, there weren't enough resources or whatever. But actually, this was a much bigger issue, and so because we experienced it every single day, we said, well, let's just lay this out on the table, because if you don't really tell the truth about these things, then how are you ever going to learn?
And it wasn't just on the sort of front line of the sort of work that Sinead was doing. Just my everyday work in a medical sense was completely stuck with politics. Every day, my staff were on strike again and again and again because they just had not been paid the money that was promised, because someone had taken it, because fake names had been put on the list. Every day, we were offered to open up a new Ebola holding unit, and someone would block it because we hadn't paid them off, and we weren't going to pay them off, and so they wanted another NGO to come who would pay them. So and then this is the point which Sinead and I would intersect it. I'd go to her or the British ambassador or others and say, look, I don't know what to do. Like, we've got patients dying outside, and I can do something, but I don't know what to do. And it was an eye-opener. There's no part of this international global health work that does not interact with politics, because it will interact with money or power in some way. And so being aware as technical professionals that is the reality we're going to go into, I think is really important. Another issue is working through government systems. So this is a photo of, you may remember, Kerrytown. Kerrytown was the so-called crown jewel of the British response. It was a 100-bed Ebola treatment unit built by the British Army and Save the Children. And the first we heard of the British, that was British going to build and run this, was on 12th of August. But the first patient they admitted was on the 5th of November. So sort of 3 months, and even when they admitted a patient, I think they admitted 2 patients in their first week. So incredibly slow process to open this thing. And so whilst that was going on, I had patients who were clamped outside. We had this exponential increase. And one of the reasons it took so long, as you can see in this photo, it was carved out of bush, out of jungle. They had to clear it, put in cement floors, they had to put in electricity, they had to put in sewage, they had to put in security, they had to create a whole new hospital. And so this decision to build parallel structures, rather than doing what we were doing, and this is a photo of a much smaller King's unit. This is at a government hospital called Macaulay Street, which is in the middle of Freetown. And so we got a phone call on a Sunday, it was the 24th of October, from the medical superintendent saying, look, we'd love to partner with King's, can you help us open up a treatment centre? Whilst the NGO goals, their construction teams worked all day, every day to finish off the design. We took their hospital staff, took them to Connaught, trained them. We were able to start admitting patients to that unit by the 31st of October. So the speed at which we could move when we worked with the existing system was critical. But so often, there's a preference for doing new builds. Some of that's political money. This cost £80 million. You know, the number of consultants, the number of flown-in advisors. There's a development industrial complex out there, but there's also, there's an understandable history that, for example, in conflict zones, often the government is part of the conflict. So there's an understandable reason why organisations like MSF would say, we can't work with the government when the government is one of the warring factions, we need to be independent. But that was not the case in an infectious disease, or often in a hurricane or in a tsunami, where you absolutely can get alongside. Yes, there's politics, you've got to navigate that carefully. But I think there's some broader points here as well, one of which is that we had been investing as an international community, as well as the Sierra Leone government, in strengthening the health system ever since the end of the Civil War. So it's been over 10 years of significant investment in that health system. And yet, the first contact with Ebola saw the whole health system collapse like a house of cards. Health workers were poorly trained, poorly motivated, hadn't been paid for months. There was no functional supply chain for things like soap or gloves. There just weren't good protocols of taps. No water would come out of them. And so clearly what we had collectively been doing to strengthen the health system had not been working. And so the importance of redoubling efforts on health system strengthening, I think, is critical. And yet, following the outbreak, I think the direction we seem to have gone in is to say, let's focus on biosecurity. Let's focus on so-called global health security, which I think is a very colonial mindset of saying, how do we in Europe protect ourselves from Africa? So how do we build a wall? How do we make sure Ebola doesn't come to the UK? By focusing on vaccines and diagnostics and surveillance systems, and rather than saying, how do we build trust between governments and their citizens and strengthen basic government health services? And we haven't seen that. We were saying this at DFID yesterday. We have not seen, despite promises, a shift in the approach to health system strengthening. And the final point is the one that Sinead made earlier, which is that our neglect of the general health system. And this wasn't just a bad thing because it meant that many people died who didn't need to. There was a humanitarian side to it, but there was a broader point. I think some people in the Ebola response thought, let's deliberately shut down the health system because it's an incubator for the disease, because it's spreading in hospitals, and because the cost to health workers, all of these doctors that were dying of Ebola, that's going to have a long-term consequence for the country. A lot of the young surgeons who had just finished specialist training, who were going to be the future leaders, they died. So there was a humanitarian consequence, but the impact of saying, a mother brings her sick child to an Ebola unit, and the Ebola unit says, well, they don't have Ebola, so we're not interested. How is that mother going to react? How is that mother going to trust you again? Why would I bring my child if you clearly don't care about me? You only see me as a vector of a disease, not as a human being. So I think that was just a really important point around health systems. Finally, it's just the importance of individuals. And I mentioned Ammar, but far more importantly is someone like Yvonne Aki-Soya. So Yvonne was a Sierra Leone businesswoman who was working in London at the time of the outbreak. And when she heard what was going on, she was determined to contribute to the response. She got on a plane, she came out to Freetown. She just turned up at the National Ebola Response Centre and said, look, I'm not a doctor, I'm a businesswoman, but I think I can help. She was made National Director of Policy for the National Ebola Response Centre. She played a really critical role in creating a much stronger Sierra Leonean leadership of that response. And some of the things Sinead said around how do we build empathy into this response, how do we put community engagement at the front, she was able to build that into the response, you know, as an individual, not as an organisation and not as a health professional, but just as someone who had the right approach and the right determination and commitment. And earlier last year, she was elected Mayor of Freetown. So she's doing amazing work now on things like improving the water and sanitation in the city, improving the accountability and the governance. So I think what we try to do in the book is talk about a lot of really inspiring people like Yvonne and what we learned from them out of the response. As a way, I think, of what we can learn ourselves if we find ourselves in this situation. And she's got a copy of the book, and we're kind of relieved, pleased that she's a fan of the book. We are going out to Freetown in a few weeks to do a series of book events there with students and the international community and the government, because we think it's really important not just to have this discussion with NGOs and governments and students and so on, but also to have this discussion in Sierra Leone, and so that's sort of the next step for us. So that was a very whistle-stop tour of the response, and of the book, but I hope it's giving you a sense of what we did and what we learned, and now I think we'd love to open this up to a discussion. Thanks very much. Any comments, questions, anything you disagree about?
So I can kick off. That was absolutely fascinating. I guess I've been looking at the cover of the book quite a lot recently and promoting the event. I feel like there must be a story behind the people on the cover.
Well, there probably is a story. We haven't been able to find it.
No. So one of the things I learned about books is that if you write a book, you don't choose the title and you don't choose the colour. Except to say you can veto it, because originally they wanted to call it The Doctor and the Diplomat and put us on the front page, and we said, hell no. And so what we did say is that we wanted this book, because I think we both felt quite a little uncomfortable as, you know, there's a history of Europeans writing books about Africa. And it's a really problematic history, and I think we struggled because we felt that the story needed to be told, but we didn't want to perpetuate that problem. But it was actually a lot of Sierra Leonean colleagues who said to us, no, you've got to write this book. You were there, you can talk about this legitimately, but also you can say things about the politics and the other things that we as people living here within the system can't really speak out about. But what was really important for us is to kind of recognise, because so often it's people like me, and it was people who, Will Pooley, who was infected and came back, and they're put on the front pages of our newspapers, but they were not, I was not the person really on the front line of this response. It was an incredible array of, and honestly, it wasn't actually the Sierra Leonean doctors either. There were very few Sierra Leonean doctors who were engaged in the response because they saw the risks as, understandably, as so great. They weren't getting medevac to London if they got sick.
And there was no health insurance for their families, so if they died, they just died. Their families got nothing.
But it was nursing students who volunteered. We had an amazing group of students who, I should show you a picture of them, because there is a story behind this photo I'm about to show you. This was a group of students, these two guys here and this guy just behind. This was our staff at the Ebola unit. This was a group of students who had volunteered when all of the nurses had gone on strike. And they had volunteered to work in the unit, and we trained them as nurses. And then several months in, this guy, he was opening a vial in the unit for an injection, and it splintered and it cut his finger, and he was scared to tell anyone because he was afraid he was infected, and so he hid it and he became sick. And what I hadn't known at the time is that actually a few months before this, he had gone home and his family in Freetown had said to him, if you can't work in that unit anymore and come back to this house because we're afraid you're going to infect this family. So you need to choose between working there and living with this family. And he and this guy, and the guy smiling just behind, said, I cannot leave my colleagues, and I cannot leave my patients, and I am committed to this country. And so they had nowhere to live. They carried on working in the unit. And the matron had found a small storeroom in the hospital. I didn't know this at the time. A small storeroom in the hospital, one mattress. They were on different shifts. They were sharing the same room. So when Sori got sick, Yoki got sick, at the same time. They were very, very sick with Ebola, and this was the moment that they came back to the hospital as survivors, straight from the hospital, and this was the kind of reaction for the team. And what we didn't know here is the third person we thought had dodged the bullet. This was day 20 of the 21-day incubation period, and the next night he got a very severe headache. He got very, very sick. But by a miracle, and actually, you know, as much as I criticised Kerrytown, actually it was incredible medical care from the British military Kerrytown that he survived. But these guys were the ones who were really, you know, driving the response. It was teachers whose schools were closed, who volunteered to work as surveillance officers. It was people who volunteered as cleaners in these units, who were really, you know, stepped up in an incredible way. And those are the people whose stories get lost. So I think that's why we wanted this cover to kind of...
But just on the cover, so we've been chasing the journalist who took the photo, because it was a photo our publishers found, and we were like, oh yeah, we like this photo. So we've been chasing the journalist to try and get the story, and we haven't had a whole lot of luck. But we're going to try to find these guys when we go to Sierra Leone and have them come to the launch and stuff like that, and then hopefully we'll be able to answer your question.
I suspect they have no idea that they're...
They'll soon find out.
That's a surprise. I mean, my colleague Marta, who was our infectious disease doctor, so her family is from rural Spain. Her dad's a local GP, and her parents were very, very anxious about her going to Sierra Leone in the first place, let alone Ebola. So she'd been telling them that she wasn't going anywhere near any Ebola patients. But in fact, she was single-handedly, you know, in the unit on her own, moving bodies, mopping the floors. You know, she's an extraordinary woman. But she was going on the phone in my office saying, no, I would never. And then a friend of hers thought they would do her a favour in an interview in the New Yorker and talk about the work of Marta Lado and how much risk she was putting herself at and how she was almost certainly going to die. And the parents got hold of this. It was actually a complete catastrophe for her. It was awful because her parents found out what was going on. So yeah, these media stories can be a shock to people.
I really, really enjoyed the talk. It was fantastic. I just wanted to know a bit more about the stigma associated with Ebola and how the public health response dealt with stigma. And recently there's been something around that in DRC Congo, and I wondered if you could teach us a bit about how to deal with stigmatizing issues.
Yeah, we didn't deal with it very well, I think, to be honest. I mean, I think eventually it improved in the sense that there was more recognition. Like in that photo, Barack Obama, so he's hugging Nina Pham. I don't know if this photo is still familiar. It was very, very significant photo for us at the time because she was the Ebola survivor, the nurse from Dallas. And we you know, sort of, I mean, for a very long time, pretty much all community issues, including stigma, were like not as important as, you know, clinics and ambulances and the sort of hardware and the response as a whole. We were much more comfortable dealing with that kind of stuff, and that sort of took our focus. But eventually, we did start kind of copping on to those sorts of issues, and also realizing the sort of vicious cycle that if you don't address those kinds of issues, then why would somebody present themselves or one of their relatives at a center? You know, there was such stigma around this. And so there was a campaign around, you know, sort of Ebola survivors or heroes, you know, this kind of thing. And, you know, the president, you know, had sort of, you know, Ebola survivor on his knee, and there were photos. And so eventually there was, you know, I think there was some work which was quite important around that. But a lot of it comes back to the broader point about community engagement. A lot of it is the sort of the difficult, long, you know, work at the community by community level of actually, you know, sort of sitting with people and explaining things and so on. It became extremely difficult when we found out that Ebola survivors could actually still be infectious, right? The whole stigma thing then took on a whole new dimension, because we had been saying, you know, once they're cured, they're fine, and you can just interact or whatever, and that's not actually quite true. So, I mean, this just, you know, just made everything immensely more complicated. I don't know, Oliver, if you...
No, I think the thing I'd add is that, you know, there was stigma for survivors, but there was also stigma for, you know, for health professionals. Like I showed you, that there was stigma in the UK and in the US. The level of stigma. Yeah. So I was very lucky. My family were really supportive, but I had colleagues who, came back to the UK, and their families, they weren't allowed to see their nephews and nieces because, many people were afraid, and the restrictions that were put on me by Public Health England, initially when I came back, I wasn't allowed to get on a tube train, I wasn't allowed to get on a train anywhere, I could only move by private vehicle, and it was ridiculous because if I didn't have symptoms, but it was, a way of reassuring the British public because, there was there's always this Daily Mail fear, the British government's constant fear. The Daily Mail is a very real thing, and the chief medical officer, they know it's rubbish, but they feel they have to put these things in place. So sometimes I'm quite critical in Sierra Leone about how political the response was, I'm saying, why can't they just listen to the technical people? But in Britain, it was completely true. A lot of the British internal messaging and response of possible cases in the UK was not based on science, and they knew it wasn't based on science, it was based on fear and stigma and media. So
the US was even worse.
Yeah.
When I started, I didn't leave Sierra Leone actually for most of this period, partly because it was so difficult, for all these reasons to leave. But I remember in 2015 when things were sort of, pretty much wound down, going to the US, and being met by a policeman at the airport with a phone and a thermometer. And every day I would get calls from, whichever state I was in, their state medical service, and they would say, what's your temperature, and, all this kind of stuff. And I was just thinking, wow, as Oliver said, it was so radically far from being necessary, but yet these were the kind of things that went on, so. But yeah, I'm not sure. With Congo now, Congo is really, really difficult now, and it is. I think it is sort of almost getting over the worst of it. What sort of friends there have been telling us that there's and of course there's a vaccination now and so on and so forth. But in terms of those community issues. And stigma, I don't think we've any kind of great successes that we can talk about. I think we've learned a few things about maybe what not to do, but I don't think we've resolved it, and particularly the survivor issue is very, very difficult.
I think we should learn more to anticipate it and to plan from it from day one. Especially the nurses, were so stigmatized by other nurses in my hospital because you had the nurses in the general wards, and you had the ones who agreed to work in the Ebola unit, and the other nurses would no longer sit next to them, and then one of my colleagues, we recruited a physician assistant who was actually based in South Africa, who's been involved in the HIV stigma work there, and she immediately saw it. I hadn't really thought about it, but she immediately saw it and said, no, we need to run a campaign. So we ran a hospital campaign, t-shirts and badges, Ebola heroes, and and it shifted the dynamic within the hospital, but it required a planned effort to make that happen, and I just didn't think about it, and I should have done. So I think part of it is from day one, building that into any program.
The only other thing I'd mention, and it was something that came out of the response to the Civil War. So after the Civil War in Sierra Leone, which ended in 2002, you had a large group of women who were known as rebel wives, who had been abducted by rebels, during the war, and had that sort of stigma, and then they were, sort of all supposed to just go back to wherever they had come from, and everybody was just assuming that they would just be integrated right back in. And one of the things in those days that helped was when those women and girls were actually given, some kind of economic, assistance in the sense of, learning a skill that they could make money from or whatever. Then it was a lot easier in an incredibly poor country for people to welcome them back, because they were like, okay, well, at least there's some, okay, we have a lot of issues, maybe a lot of complicated relationships with this person who we associate with the rebels, even though, of course, if we really think about it, this is actually one of our own people who was, but anyway, but actually that did seem to help, and so it was one of the things that I and others raised as something that needed to be done with Ebola survivors. So not just, sort of, because Ebola survivors, will have health problems for the rest of their lives, to various degrees of severity. Eyesight is a huge issue, various other issues. And so there was all these programs being set up, medical programs for Ebola survivors, and sometimes even psychosocial and mental health, which was something that did actually make a good bit of progress during the response. And then, you know, some of us, and I think Partners in Health in particular, the American NGO that Paul Farmer is involved in, they were actually quite good at looking at the more economic side of things. Well, let's get these people jobs, you know, and that'll make their lives easier in a number of ways. It's not easy, but I do think that's one of the things we should be thinking about for Stigma.
Hi, that was really fascinating, thank you. I'm actually from Defiller, I've just retired. So I was looking forward to this talk to see, you know, what you would be saying. In terms of getting to zero, the family members would have been the first line of contact with the patients.
Yeah.
What were one or two of the critical changes you would have seen amongst families to get to zero?
Mm. And I think you're asking the right question, which is recognising that the change happened at the family level, because there's a lot everyone wants to take credit. A few things happened simultaneously, and I don't know if we've got a picture of the graph here of the actual outbreak. Here we go. You know, it went from, you know, in December, this is new cases per week, so we were seeing about 600 cases per week. Bear in mind, the British response said we're going to build 600 beds, and that's going to be enough. We're getting 600 cases a week. So, you know, it was unbelievable numbers, and look how fast it dropped. This is the space of about, you know, 6 weeks, a month, 6 weeks, and it went from 550 cases a week down to 50. So there was this extraordinary drop that happened simultaneously, and everyone was saying, well, what happened? And some people said it's because we changed the burials. They thought a lot of the contact was happening at burials, the touching of bodies. Not sure how much evidence there is for that. Not sure how much the British Army were doing the burials, just wants to claim that they sorted it all out. Some people said no, it was to do with the beds, because there was a sudden opening up of a lot of treatment beds at this stage. People who were sick at home, rather than being quarantined with their families, could suddenly go into a treatment centre immediately, within moments. And when you first have symptoms of Ebola, you've got a headache and you've got a fever, but you're not that infectious. It's when you start having vomiting and diarrhea, so-called wet patients, or you're bleeding, then you're very infectious. So by isolating patients a few days more quickly, you could really switch the balance. But there's another group who says that's nothing to do with it. In fact, the response was nothing really to do with it. What was happening at an individual community level is at a certain point, there had been so many cases that people began to take it as the most important thing that's happening in their community, and they started to, a lot of the conspiracy theories that this was just being made up or whatever, starts to dissipate when so many members of your community have got sick and died. And so the idea was there was sort of a turning point at that moment where people were much more forthcoming, where cases occurred and began to change their practice. But it's very difficult because the messages we were giving to families from the beginning were things like, and this is this issue of our failure in community engagement, there was a complete lack of empathy. There was a failure across the board of us to say, well, if this were me on the receiving end of this message, would I do this? You know, Sinead, you mentioned something yesterday about how there was a big, in order to demystify ambulances and to make ambulances less scary, there was a program of taking ambulances to communities, opening them up and letting people, community leaders, see the inside of an ambulance. But actually the fear of ambulances was completely rational, because for most of the response, every time an ambulance picked up a patient who would be vomiting and bleeding, we wouldn't clean it before they went up to pick the next suspected case, not confirmed, suspected case. Would I have got in the back of a Sierra Leonean ambulance? Hell no. Unimaginable I would have got it into the back of an ambulance.
But we would just say that people were irrational.
Yeah. Why aren't they just...
And that they were resisting.
Yeah.
And absolutely not putting ourselves in their shoes. And I mean, one thing your question reminds me of, I mean, this is a controversial point, but we talk about it in the book anyway. You know, for so much of the response in Sierra Leone in those early months, for so many of the people that were infected in those first, say, 6 months between May and, you know, when beds really started to open in December, there was no bed available for most people. And so, you know, some of us tried to get like these kind of kits, and I know King's, you did do some of this, you know, some of these kind of like home care kits off the ground, you know, you know, so basically the notion of, okay, you know, you're being told, you know, the instructions are, you know, if you think you have a suspected case, you know, you call 117, but actually for so much of the response, if you called 117, they would say thank you very much, and it would go back to that whiteboard with the 0, and you would just be sitting waiting, and then at risk of infecting your family members. So we were saying, well, at least let's get gloves, let's get soap, let's at least be able to do something while people are waiting for these beds. And it's a controversial point because people say basically it was shut down, and it was shut down partly by the British government who didn't believe in it. And there's some good rationale behind that, because there's this concern that you would lure people into a false sense of security by giving them gloves and so on and so forth, whereas what you're really supposed to be saying is don't touch anybody. Now if you're a mother and your child is sick, are you going to touch your child? Of course you're going to touch it. It's ridiculous. And we were saying, no, don't touch anyone. It was ridiculous. So again, this point about empathy and putting ourselves in the shoes of these people, and sort of saying, well, would I do that? And what would I, and how are you going to find this out? Well, actually by sitting and listening. What is it that would actually help people to overcome the situation themselves? Because for a lot of the response, we didn't have the beds available, so we were going to have to come up with something else. And for a lot of the response, we were just like, sorry, we'll just keep telling you to call 117, even though we know that if you call, we're not actually, going to be able to do anything. So I really think that point about empathy, this is why we say community engagement is absolutely the biggest lesson.
And just to finish on community engagement, every time Sinead does that slide on community engagement, I feel quite guilty, because I thought community engagement was important, and we had a community engagement pillar of the response, and I was like, that's good, there's a pillar, that's their job. And what I didn't really realise is that community engagement was also my job. It was everyone's job to do community engagement, because every time I was interacting with a member of the public, the way I was behaving was they were going to go back and tell their community members. So the way in which our Ebola unit looked, it was at the front of the main hospital of the country, and it was in the front of the newspapers. And therefore the way we designed it, with tarpaulin and no entry signs and hazmat suits, was giving an impression to the public. And I was just thinking about, how do I keep my staff safe, and I'm overwhelmed with patients, and I wasn't thinking, and so I think that point around, would I, as a discipline, if I were in this situation again, not in any situation where community engagement is important, which is most situations, I would have stopped at every decision, in every meeting, and said, pause for a second, this decision we've just made, how are other people going to experience this, how are other people going to interpret this as a sort of intellectual tool to constantly stop ourselves and ask ourselves that question, because otherwise you get so overwhelmed by the nuts and bolts of beds and ambulances, you lose track of human experience and the social condition that's behind it.
Ebola is 100%. It's a social disease. It's got to be one of the most social diseases there are. But we just.
The question now, sorry, is going a bit back to what you said about the picture and writing the book and having this kind of colonial view that really irritates me. That we assume a very patronizing view of Africa, India, whatever. This thing of, we and us. There is no we and them. There is no we and them. We are just all human beings. We live in the same world. We are born exactly the same, and we'll die all exactly the same and have the same fate. That's it. And this thing of thinking, we are the developed countries, humanitarian aid. The point to me now is, how can we really strengthen the health systems? How can we empower those people? Instead of going there and building a hospital from scratch, very shiny, that people don't feel comfortable working with, they don't know how to operate with that. It needs to be, that's why I think you were more important than the aid that went, the expert aid with the kids and everything from here. Because if you don't know how to work with people, if you don't know the reality, if you are not embedded in that culture, you can't really do anything. The solutions that work here in the UK with our mindset won't work there. And that's what happened with our facilities. I'm Portuguese. We had lots of facilities and buildings and structures. And then when we left the colonies in the middle of the 20th century, everything was ruined. because they didn't know how to operate within that system. They have their own mindsets, they have their own culture, even what to us seems corrupt. For a lot of people there, it's just the way the world works, and it's tricky to enforce our principles, our way of life, our political regime. You know, it's very, very difficult. To what point are we not trying to force people to live a life that they don't want to live? But on the other hand, we have all these things, human rights and equality. But we need to understand that it's always the conflict between cultural relativism and cultural absolutism. Is our culture, is our principles, our values, are them better? Is there any Western civilization way of thinking that should really conquer the rest of the world? This is a bit of the imperialist thinking of the United States, and it's never going to result very well. That's why in Africa we have politics and politicians and dictators that are somehow supported or sponsored by some Western countries. But then the country doesn't work, and there is a lot of revenge.
And I think, you know, going back to this idea of working with government systems, one of the really good reasons for that is it ensures that democracy is not perfect, but it's a democratically elected government, and they're the people who should be making decisions about their population. And so by working through government systems, you're automatically in a much closer partnership arrangement rather than, and I think it was a real challenge of, some of the colleagues at the Ministry of Health in Sierra Leone talked about their frustrations with British 20-year-olds like me turning up and trying to tell them what to do, and they're the director of hospital, whatever, and the power of money was used to often leverage things in unhelpful ways.
From being there, how do you think that actually what can be done to strengthen the health system so that the next time Ebola comes, we don't really need, they are able to contain it and they are strong enough to respond?
Do you want to answer that one?
Yeah, I think we know the WHO, universal health coverage is the primary agenda of the WHO, and that's a good start. The WHO sets out 6 building blocks of a health system. We know leadership and governance, and we know what they are. But I think we just need to. There's such a temptation always to focus on the disease and the photo op with the pregnant woman, and starting with the disease, and then realizing, well, we're trying to improve maternal mortality, but actually there are no midwives and there is no supply chain, and then people trying to kind of retroactively build a health system from the patient backwards, creating huge amounts of parallel systems and vertical programs, which we would never do in the UK, rather than recognizing that medical schools or effective drug supply chains and everything else needs to be in place, and that stuff. Sinead talks about a generational investment. You can't do these. Diffid says, yes, we've got a 2-year program to 2 years is not enough time to, as British government is finding out at Brexit, 2 years is not very much time, so it's quite complicated. And so, this need to shift much more to generational investments of real strategic, parts of the health system. It is something rather than always just trying to tinker on the outside in, because it's easy for us.
Do you think teaching and training, what I mean is either sponsoring people from those countries to come either to the UK or to any kind of Europe to study medicine and nursing, or is it better to go there or invest and develop a school?
I think both. I mean, there's a huge amount in what you said. I think we could probably spend the rest of the day picking it apart, actually. And I mean, I'm in this sector in Africa for the last 20 years. Sometimes the more you know, the less you know, to me, a lot of these questions don't have answers. They just need to be figured out in the context. So you have a certain, you will have certain personal values. You will be working for an organization that hopefully has values that you believe in, and I think you need to try to understand where you are and have strong relationships where you are, and then try to figure out what's the best thing to do. And one of my criticisms of a lot of our sector is our lack of flexibility to actually make those very context-specific decisions on what exactly is the best way, you know, for, you know, in this particular context. I also, as Oliver knows very well, I'm really not a fan of political correctness, and I think, you know, sometimes we can go too far on the sort of saying, you know, oh, well, you know, this is, you know, people's culture and all that kind of thing. I think there are times in which, you know, things that happen in my own country or in another country where I'm working conflict with my values, and that's, you know, then, you know, maybe it's time for me to exit the stage, you know, not necessarily that people can't do what they want, but that they probably shouldn't be doing it with my taxpayers' money, for example. So I guess my point is all these things are so tricky and difficult, and there aren't easy answers, but to me, the answer is you go where it is you're working, you try to you know, to figure things out, and then you see, okay, is there a role that I can play? Sometimes there is, sometimes there isn't. That's useful for you know, whoever it is that I say I'm trying to assist. And I think sometimes probably what organizations don't do enough is actually say, well, actually, no, there isn't a role for me here, you know, for whatever series of reasons. But to me, it's very much about having the flexibility to make those decisions, whereas what we tend to do sometimes is say, well, I have a big 5-year program and I'm doing it in these 8 countries and it's the same kind of thing or whatever, and not really engaging with the context where we're working. So
my new PhD at the moment, I'm looking at how to support early career doctors in Sub-Saharan Africa to develop their leadership capabilities, because I think ultimately all the programs that were successful that King's was partnering with in the hospital in Sierra Leone are programs where there were really colleagues there who were excited about them and wanted to drive them and lead them, and our role really was to support them in that process. And where they didn't exist, it was actually damaging to try and, you know, we had our log frame for DFID that we had to meet, but actually it wasn't something that was even seen as a priority there, or it wasn't something that there was someone who really wanted to take responsibility and commit their lives to over the next decades to making happen, and therefore all we were doing was kind of ticking boxes and spending money, but it was never going to be something that was sustainable. So the really interesting question I'm trying to look at is, how do we support early career doctors who, age 24, 25, there's an amazing guy called Mohamed Boyjallo, who was I knew him as a medical student in Sierra Leone, and then he had graduated 2 months before the Ebola outbreak. He was an intern doctor at the military hospital, and the head of the military hospital said, we want you to run our Ebola unit. So he ran that Ebola unit, and then on a Friday night he got a phone call a few months into the outbreak, and the president was opening a new government treatment centre with 100 beds the next morning. But the government doctors who were supposed to run it were on strike, and so he was told at about 10 o'clock at night to go down so that it was ready to be opened at 8 a.m. the next morning. So 2 of them went there and they found some beds that were still clean that patients hadn't used. That they put them in a storeroom, and they lived in the treatment centre for months. And they just did an extraordinary job, you know, motivating their team and the courage and the integrity that they showed, the commitment the level of care they were providing to their patients. You know, and so how those guys, how do we support them in their careers, but also how do we support others to develop the same kind of, you know, approach and skills. So that's kind of why I ended up focusing on what I have, because I think it's the starting place for a lot of this change.
Very interesting presentation, and just to add to what you've been saying regarding to the what we should do to improve the health systems back in Africa. I think, you know, I don't know more about West Africa, but I can say something about East Africa, which I think there is no like shortage of healthcare professionals. There are enough healthcare professionals trained by the countries, by every country in East Africa, but the problem is they don't stay there.
That's what.
And the problem is, the main problem is the political
even
issue.
those who
So
can't
that's where I really
governance.
the governance problem.
Yeah.
And as long as that thing is there, there's always going to be another disease, maybe not Ebola, but maybe another one with a similar impact. And I don't see it like that issue being addressed as most crucial thing, not only for non-infectious disease, but for infectious disease, but also for non-infectious disease.
It's the brain drain, is what they call brain drain. days I had here in training, they came to train and they decided not to go back. So
Well, but I mean, I think what your brain drain is a symptom of a fundamental underlying governance issue. I mean, trust me, a lot of us are trying to work on governance. It's very difficult to know. I mean, because fundamentally, what improves governance? Actually, it's citizens of the country really, kind of somehow gaining the power to be able to change who's in charge. I mean, your part of the world has the most fascinating governance developments over the past 12 months. It is just extraordinary. And as we were talking about earlier, it's very difficult to know what's going to happen. Look at Sudan at the moment, very difficult to know what's going to happen. And again, I think this comes back to my point about you don't know what's the best way to assist someone if you're sitting in Oxford or in Dublin or in Geneva or in New York. You need to go and understand where you are and then say, well, okay, based on this then, this is maybe an opportunity. I mean, this is sort of how I try to work, a little bit like what Oliver is saying with Mohamed Boy Jallow, in South Sudan at the moment, to try to identify some people who are, doing the right thing, who have the commitment or whatever. It doesn't really matter who they are. They could be working for government. It'd be nice if they were working for government. They could be NGO people. But, if I identify these people, which I inevitably do, then how can I support these people? And sometimes it's moral support. Sometimes you can't fund them, or they don't even need funding or whatever. They don't have any projects or whatever. But it's just to say to them, I like what you're trying to do, and keep going. Because sometimes people can be very isolated in bad systems, and can feel very alone because they say, oh, everybody else is, taking bribes and this and that, and if I'm not taking bribes, everybody thinks I'm a fool, and this kind of thing. And how did governance improve in Western countries? I'll tell you how it improved in my country, because when I was a child, it was still in Ireland, it was still lots of brown envelopes and bribes and so on going on. I think a lot of it was education. The decision in the 1950s to have free secondary education in Ireland made a huge difference eventually to our governance. And so it's these kinds of generational investments that I think governments need to make. And then the question is, as internationals, do we have a role in helping with that? I think ideally we do, but it's very context specific.
Can we also say health education to make it more precise? Because the problem is even healthcare, like a lot of people could be educated up to university level, but the problem is their awareness regarding health is very limited. So I think this is something which could be done easily with little investment, but at the same time the benefit is going to be long term, because now we have crises of both infectious and non-infectious together, and and with increasing population that's going on in Africa, that is going to be huge burden not only for Africa but also for Europe, because now we see a lot of issues with migration, and now we're just focusing on building walls, which I don't think is...
We actually don't see that much migration. We just think we see a lot of migration. The numbers have plummeted.
Yeah.
Anyway,
But
that's another story.
One thing I just want to say is, always when crises like this happen, we focus on what we can get from Western countries, from what we think are developed already. But we never mention how the countries in Africa can collaborate and try to help each other, because that part is actually missing. And I was wondering, did any country from the West, from the East or South, even contributed anything to this crisis?
There were definitely, there were Ugandan health workers brought to, because they had experience of Ebola. The AU did some work around this, the WHO did some work around this. It's happening a lot now in the Congo. There's a lot of Guineans in particular in the Congo because of the French language. So it is happening. I think a part of it is to have a stronger African Union to push these kinds of things. And now there's this African Centre for Disease Control that was again pretty much a direct result of this Ebola crisis. So on the sort of epi side, I think. So yeah, partly about strengthening these kinds of organizations. And I think Western countries do have a role in that. And generally that kind of thing, Western countries are pretty happy to invest in that kind of thing. But it needs to obviously be organized. Yeah.
So
I think we're probably over time.
Yeah, exactly.
Thank you so much. But we'll bring a pile of books to your table, and then I'm sure
Great.
that you can take other questions.
Yeah, and if, all the proceeds from the book are going to Sierra Leone, so some to a school for the deaf in Kenny, run by some amazing Irish nuns,
That's right.
and one to medical students at the medical school in Sierra Leone.
And Oliver has a fancy card machine.
I do have a card machine.
I don't know how to work.
£10. Great Christmas present for next year. That worked better last time.